All right, we can get started then. So I'm Michelle. I know I haven't met most of you. I met everyone here in the room. And I'm one of the PGY1 pharmacy residents that I worked with Jeffrey last month. So today I'm going to talk about anticoagulation, mostly warfarin with a little bit about the DOACs toward the end. So the objectives, first we can talk about indications for anticoagulation, the mechanism of warfarin and how the mechanism of it relates to how we manage warfarin. Talk about appropriate counseling and monitoring points for patients receiving any type of anticoagulation, developing a dosing and monitoring plan based on their INR and any transient factors that they have present, and then recognizing where DOACs could fit into therapy if a patient maybe isn't the best candidate for warfarin. So indications for anticoagulation, I think of it as kind of two main areas, so either treatment or prevention. So you could be treating a VTE or venous thromboembolism, and this could be a DVT or a PE. And these are treated differently for different durations based on if it was provoked or unprovoked, or if it was their first event or a repeat event. And then there's prevention. So patients who have atrial fibrillation have a higher risk of clotting because the blood can't flow smoothly from the atrium to the ventricles. And so they are often candidates for anticoagulation, and this is determined based on, it's called the CHA2DS2-VASc score. And so depending on that score, they may only require aspirin or they may require full anticoagulation with warfarin or a DOAC and so on. Then there's also patients who've had heart valve replacements, and if their atrial fibrillation is because of this, then this would be treated in valvular atrial fibrillation type of treatment rather than non-valvular atrial fibrillation, and this will come up later in the presentation. And so the valves can either be mechanical or bioprosthetic, and they can be in the aortic position or the mitral position. And this is important because this also changes the way we treat patients with their INR goals or the medications that we can use because of the different valves being higher or lower risk from one another. And then there's also hypercoagulable conditions, and there are many of these. I think the most common one that you've probably seen is antiphospholipid syndrome. So those are the types of things that would fit into this category. Okay, so there's many different types of anticoagulants. There's heparin and the low molecular weight heparins like enoxaparin or Lovenox. And then there's warfarin, which was the first oral anticoagulant. And then the more recent agents, the DOACs, which are direct oral anticoagulants. And then there's direct thrombin inhibitors. But those are mostly used inpatient, and so we won't be talking too much about those today. And the most of this presentation will be focusing on warfarin, as I said. So the background of warfarin and the actual way that it works. So it's a vitamin K antagonist, specifically a vitamin K epoxide reductase complex 1 inhibitor. So this pretty much means that, so when the body makes clotting factors, it needs vitamin K, and the vitamin K goes from active form to inactive form once it makes these factors, and then the body normally will reactivate the vitamin K into active form so it can continue to make more clotting factors. But when we give a patient warfarin, it prevents the conversion from inactive to active vitamin K, and so without the vitamin K, it reduces the hepatic synthesis of multiple clotting factors, specifically 2, 7, 9, and 10. And then another part of the mechanism that is not part of why we use the medication is it also decreases protein C and S, which are the body's natural anticoagulants, which you may think is kind of opposite of what we're trying to do. And so that's why it's important to know about those, which we'll also talk about a little bit more in the upcoming slides. So the reason the mechanism is important, there's a lot of medications where from a nursing perspective, you may think that there's certain parts of the mechanism that you don't need to know in such detail about for how you're utilizing them. But for warfarin, the mechanism really is important because it changes the onset of action, whether you need to bridge anticoagulation or not. There's multiple drug-drug and drug-food interactions and monitoring, which are all affected by the way that drug actually works. So as I said, it prevents the synthesis of new clotting factors. And so this is important to know that it's new clotting factors, and so the clotting factors that are already present in the body are not affected. And so that's why the onset of action is 4 to 5 days. So the factors that are already there can continue to be used and make clots until they're naturally degraded by the body. And so this chart shows their half-life, and this is the average half-life. So depending on the patient, they may be shorter or they may be even longer than this. So factor 7, which is one of the clotting factors, is only 7 hours, but that's actually, it's not as potent as some of the other factors. So factor 2 is the one that really has the most effect on clotting, and that has a half-life of 50 hours. And so in a lot of patients, it's even longer. And so that shows you kind of why it takes so long to really start working. And then the bottom two, protein C and S, specifically C, you can see the half-life's only 8 hours. And so when a patient first starts warfarin, within that first day, their protein C will be pretty low. And as I said, that's the body's natural anticoagulant. So at first, many of these patients are actually in a procoagulable state and are at higher risk of clots when you're starting warfarin. And so this is pretty dangerous for a patient who we're anticoagulating, so they're already at a higher risk for clotting. And then we're decreasing their protein C, putting them at an even higher risk. So depending on the patient and different indications for anticoagulation and specific factors, this would be why sometimes we bridge to warfarin. So before I talk about bridging, it's important to understand what the INR is actually measuring. So this is the international normalized ratio, and this is a measure of, it's actually looking at PT, or the prothrombin time, but this is a standardized version of it. So depending on the institution you're at, there's multiple different reagents that can be used to measure the PT, and so the number could come out a little bit different depending on the laboratory you're using. But the INR can take this number and change it into a standardized number that can be used at all different institutions. And so if you get an INR of 1.3 here at UVA, you should get the same INR if they do the point of care testing at the clinic or at a laboratory at Martha Jeff, and so on. And so this is what the INR is looking at, and this is the standard of how we monitor warfarin. So a higher INR is more likely for bleeding, and a lower INR is more likely for clotting. So the goal INR is patient specific and is based on the indication. So the chart here on the right shows multiple different indications, and you can see most of them are 2 to 3. So for non-valvular AFib, treating of venous thromboembolism, surgical prophylaxis, and then also some of the hypercoagulable disorders, they're all 2 to 3. But then a mechanical mitral valve is 2.5 to 3.5. And that's because mechanical valves are at a higher risk for clotting than the bioprosthetic valves. But then also the position of the mitral valve is at a much higher risk of clotting than the position of the aortic valve. And so that's why even if you have a mitral valve, which is at a higher risk, if it's bioprosthetic, which you can see on this on the third row, it's still 2 to 3. And that's because the risk shifts based on if it's mechanical or not, and then also the position. So generally, no matter what their goal is, the 2 to 3 or 2.5 to 3, we can start warfarin in most patients around 5 milligrams a day. But if they do have risk factors for causing them to have a supratherapeutic INR, so if they're already on interacting medications, if they have older age or hepatic dysfunction, then those patients may be started lower with 2 milligrams. There have been studies that looked at starting higher with 7 or even 10 milligrams, which was used for a little bit back before other studies came out, but now it looks as though these patients didn't actually get therapeutic any quicker, and they also had higher risk of bleeding. And so that's kind of fallen out of favor, and now we don't usually start with more than 5. So you're talking about bridging. So as I said, when patients are starting warfarin, any of them could be in a procoagulable state, and so really any patient starting warfarin is a candidate for bridging. But this is still something that there's multiple studies coming out with differing opinions, and so it's kind of provider specific depending on the indication. But patients who definitely should be bridged, no matter what, are if you're treating an acute clot, because you need to actually treat the clot right away, and you don't want to wait the 4 to 5 days for the warfarin to kick in. If they have a new valve placed, because those are at higher risks for clotting. And then if you were to ask me, I think any patient starting warfarin should definitely be bridged, just because of the risks of those 4 to 5 days being in a hypercoagulable state. So if you have a patient that you see, it never hurts to ask if you want to ask their provider. It may just be their practice that they're not bridging in a certain patient, but it never hurts to ask if you think, oh, maybe this was forgotten on this patient, because I have seen it forgotten many times when patients leave the hospital and then they come back in with a clot. So definitely something important that you can make a difference with. So if we do decide to bridge, we usually use injectable anticoagulants because these have an immediate onset of action. So low molecular weight heparin or like Lovenox could be used outpatient because it's a subcutaneous injection. And so this is usually our first line, just so that if patients are admitted, they don't need to stay in the hospital for the whole 5 days of bridging to be on a heparin drip. But it becomes a problem in some patients if they have renal dysfunction because enoxaparin is contraindicated if the creatinine clearance is less than 30. And so these patients you may see staying in the hospital with a heparin bridge, and then if you see them in clinic later, then that's probably, if you see them in clinic later and they had a full length of heparin bridge rather than Lovenox, this is probably part of the reason for that. There's also some recent data coming out, which I think in the coming years this will probably be even more and more popular, is using apixaban as a bridge, specifically in renal insufficiency, because this is the DOAC that has the least renal clearance, so it's usually safe in patients with renal dysfunction, and then it's oral, so they don't need to stay in the hospital to get a heparin drip, even if they're not a candidate for Lovenox. And then the last one, fondaparinux, this can also be used outpatient, and this is usually used if a patient has had any history of HIT or heparin-induced thrombocytopenia, which is an allergy to heparin, and so this is appropriate to use in those patients. But it is a bit more expensive, and so I feel like we don't see it as often, and it also has restrictions for renal dysfunction as well. And so patients who are being bridged, we usually bridge for 5 days, overlapping with warfarin, and then also having 2 therapeutic INRs. So if they have 2 therapeutic INRs within the first day or two, we want to continue to bridge because that's most likely driven by just some of their factors being reduced, and then that their protein C is still lower than those main clotting factors that we were talking about, like specifically factor 2. And so those patients we want to continue to bridge until we have 2 therapeutic INRs plus the 5 days overlap. And they would probably have a decreased dose at that time as well. Also, if we reach our 5 days and we still haven't had 2 therapeutic INRs, then we continue the bridge until we get 2 therapeutic INRs consecutively in a row. So you need both of the standards to be able to complete the bridging. So warfarin is known as one of the narrow therapeutic window medications, and so this means that the amount of drug that you need to treat the patient is very close to the amount that you would need that would actually be harmful to the patient. And because the levels of warfarin can be so variable depending on your patient-specific factors, this is why we worry so much about monitoring. And so the main adverse effect that you could even definitely make a difference with, whether you're seeing a patient for INR monitoring or if they send a message via MyChart or call the clinic, if they have questions about bleeding and they're on an anticoagulant, there are kind of two ways to think about it. So it can either be minor bleeding or major bleeding. So minor could be they could see some blood when they brush their teeth, which is usually seen more often in the beginning when they start an anticoagulant, and then once their body gets used to having that anticoagulant on board, this should taper down and not be so evident to them anymore. It could take them a little bit longer for smaller cuts to clot off. So if they were cooking and cut their finger, just the way you or I would, they could hold pressure on it, and if it stops bleeding within like the 3 to 5 minutes, then they shouldn't be worried and they shouldn't need extra care. But if they're telling you, it's been 10 minutes, 20 minutes, and it's still bleeding and it's not dying down at all, then that might be something they want to be seen for because they could have high INR. We can tell them they would have a lower threshold for bruising. So if they kind of like bump into a piece of furniture and get a bruise, then that's perfectly normal. But if they tell you that they're noticing multiple bruises and they don't really have a known reason, then that's something we might be a little bit more worried about, and then they would want to be seen. And then if for female patients, they may notice a heavier menstrual bleeding. So most of those things would all be normal side effects that you would see just because we're thinning the patient's blood. But if they're telling you that they have red or dark urine, blood in their stools, they may be dark tarry stools, if they're vomiting or coughing up blood at any point, or are expressing severe headaches, as well as the bruising for unknown reasons, as we were just talking about, then this is the time then we probably want to send them in. And depending on the severity, they could either go to the emergency room, specifically like the blood in the stool or vomiting, or they could make an appointment with their provider as soon as possible. But oftentimes, depending on especially if you're on the phone and you're not really sure how severe it is, you could always just send them to the emergency room just to be sure, just because the risk is very high. And then another important thing to know, if a patient has any type of serious fall or they hit their head, even if they don't see any signs of bleeding, then they should definitely come in to be checked, because there could be bleeding, especially in their head, which could be dangerous, that we just aren't aware of from the outside. And so this is a rare side effect, but I thought it was important to bring up. So this has to do with usually in the beginning when we first start warfarin, when the protein C is lower. Like we were talking about, the patients can be at much higher risk of this. So it's called purple toe syndrome or skin necrosis. There's a picture here on the right, and it could be much more severe than this or much more mild than this. But if a patient, so they may think, oh, my toe's purple, and not be really that concerned about it. But if they're telling you that and you know that they're on warfarin, especially a new start, then this could be something that rings a bell to you that they may need to be seen. And so the way that we would deal with this is to tell them to not take their next dose of warfarin and to seek medical care right away. And so usually this is increased when we don't bridge patients because we have more effects of the protein C deficiency, or in patients who have protein C deficiency at baseline without warfarin or antiphospholipid syndrome. These are all patients who are at a higher risk of having this adverse event happen to them. And so a lot of times we focus on the risks of bleeding with warfarin because it can increase those risks, but then we also want to think back to why patients are on anticoagulation in the first place, and this is because they are at a higher risk of clot. So in case their warfarin is subtherapeutic, if they're expressing any signs of shortness of breath or chest pain, this could be signs of them having a PE or a heart attack, meaning their warfarin is not doing the job. They could have redness or warmth, swelling in their arms, legs, or feet, which could be signs of a DVT. Or if they tell you about any changes in eyesight, confusion, or vision changes, these could be signs of a stroke. So these are also things to mention to them, because a lot of patients when they're starting are mostly just worrying about bleeding, but they forget about there's also the risk of clotting with their condition that they had before they started their warfarin. So I have a question, and this is about FM. So he's been taking warfarin for about 3 weeks and tells you that he saw some blood when he brushed his teeth about 1 week ago, and then this morning when he flossed. And so he would like to know if he should come in and see his doctor today because he was concerned for bleeding. And what could you tell him? So choice A, that it's normal because warfarin is a blood thinner and this is mild bleeding. Choice B, that it's a sign of likely a supratherapeutic INR and that he should be seen as soon as possible. C, the gum bleeding, if the gum bleeding becomes more frequent or increases in volume, he should see his doctor. Or D, A, and C. Yes. So that's correct. So like I was saying earlier, that this can usually be more prevalent in the beginning when the body is still getting used to having anticoagulants on board, and then it should then become not a problem for them. But if at any point, if they're telling you that they have this every single day, or if the volume is increasing, then we may want to have them come in and check their INR to make sure it's not too high. And so then there's also some counseling that can be done about interactions. So warfarin is one of the main drugs we see that has a lot of food-drug interactions. And this chart here at the bottom is actually in the patient handout that we have in the UVA education repository we give to patients. And so it shows them the foods that have the least amount of vitamin K and the most amount. And so this is important because vitamin K is used to make these clotting factors, and the dose of warfarin that they're on when we measure their INR and they're in a therapeutic range, that's blocking the amount of vitamin K that their body is used to having. But if at any point, if they're increasing or decreasing the amount of vitamin K they're intaking on a normal basis, then their dose may need to be adjusted for that. And so the most important thing that we can stress to patients is that they don't need to avoid these foods because they do have nutritional value for many other reasons as well. They just want to try and remain consistent. So the amounts of these foods that they're eating each day. And so this chart is also on the patient handout, and so this can give them a good idea to see how much is in each food, and so they can add up, but they don't even need to do this, but some patients who are even more into kind of tracking their health, which we've definitely seen in a lot of our patients, they may want to even add up the amount of vitamin K they're eating each day, just to see and make sure that they're pretty consistent each time. So the top is the foods with the highest amount of vitamin K, and so these are the green leafy vegetables, and then the bottom is the lowest. So a lot of fruits have vitamin K, but they have less than like kale and spinach and those types of salad types of foods.
So if they're eating spinach once a week, and that's what they do, it's not that it has to be consistent every day, but sort of generally over a week, or?
Yeah, so if we've been checking their INR pretty consistently and they've always been within range, then and so every time you talk to a patient, whether they're coming in the clinic to have their INR checked or you're talking to them over the phone, we just want to ask them about any medication changes. So specifically prescription, over-the-counter, vitamins, and then a lot of times patients don't think about herbals or supplements as medication, so we want to specifically mention those words to them to make sure they know that we're thinking about those as well. And so specific ones that could ring a bell for an interaction with warfarin, if they tell you, are garlic, and so that's not putting garlic in your food, it's more the higher amounts of garlic, because there are garlic capsules that some patients can take. So garlic capsules, ginseng, ginkgo, ginger, St. John's wort, and excessive amounts of grapefruit juice are all things that could potentially affect the INR. And so usually with these, we try and have patients avoid them, but if some patients are very attached to their supplements, and so if they are consistently taking these as well, and their INRs are well controlled, then it could be okay. It would just be a patient-specific conversation. And then we also try and have them avoid any NSAIDs because these can increase the risk of GI bleeding. And so a lot of times this is also something that patients might not realize because there are so many different names. And so if you just have them tell you, like, oh, what do you take if you have a headache? Sometimes you realize they are taking one of these, even though when you ask them if they're taking any medications like ibuprofen or Advil, they may say no. But then when you ask them, like that when you're asking what they take for a headache, they may say, oh, I take Aleve, and they didn't even realize that was an NSAID. So that could help to phrase it in that way. And then any aspirin-containing products, because these can impair platelet function, and so then they increase the risk of bleeding as well. And so some of those are listed here. And one I thought was interesting, I've noticed a lot of people don't realize that Pepto-Bismol is an aspirin-containing product, so just something I thought to point out. And then there are the drugs that we think of more when we immediately think of drug-drug interactions, so the prescription medications. So antibiotics can usually increase the INR, and that's because antibiotics, when we're taking them for an infection, they don't know specifically what bacteria to kill, and so a lot of times they are also killing bacteria in the gut unintentionally. And usually in our normal GI flora, these are making vitamin K, and so when this bacteria is killed off, the amount of vitamin K is decreased, and so then the INR can increase. Then there's also interactions that have to do with the metabolism of warfarin. So you can see at the bottom of the screen on the bottom left, when warfarin goes in the body, there's actually two different types of warfarin that are in the chemical that it splits into. So there's R warfarin and S warfarin. So S warfarin is the one that's responsible for most of the vitamin K inhibition. And so that's the one we worry about the most with interactions. And so that is metabolized by CYP2C9. So on the chart, I bolded the medications that are either inhibitors or inducers of 2C9 because these are usually the ones where we see the most effect on INR when patients are taking them along with warfarin. So some of the big ones, such as Bactrim, Flagyl, any of the azoles, amiodarone, these are all things that we may, if a patient is starting on these when they're already stable on warfarin, we may empirically reduce their warfarin dose, or if they are already on one of these medications and then start warfarin, we may start them at a lower dose. And then rifampin and phenytoin are inducers, and so these can decrease the INR, and so we may increase the warfarin dose. So some warfarin counseling points when we're talking to patients is they need to, for sure, we want to stress that they tell all of their providers that they're taking this medication. So even if they're thinking it's something completely unrelated, a lot of times patients forget about the dentist because usually they're not getting medications from there. But they can also be doing procedures at the dentist that can increase their risk of bleeding. So we just want to stress to them that they tell anyone who's doing anything with their medical care that they are taking warfarin. And this is because before surgeries or procedures, they may need to hold the medication, or if they were to start bleeding, then the way we would treat that would be different if we knew the patient was taking warfarin versus if this was someone who wasn't taking warfarin. We can also let them know that they should take the medication every day about the same time, and this will help them to have more continuous protection, and then their INR won't be fluctuating as much when we do check it, and we won't be making dose adjustments just because they were taking the dose at a different time each day. Sometimes, though, patients do miss doses. They may forget or not be home, and so this might be a call that you get because patients can be worried that they're worried if they take it, they'll bleed. If they don't take it, they may clot. And so for this medication, because it's once a day, we can tell them that as soon as they remember, if it's within that same day, that they can go ahead and take the dose. But if it's the next day, if it's less than 8 hours until they usually would take their next dose, I would have them hold off and just take the next dose at that time and skip their missed dose. So they would never be taking 2 doses at the same time. And because this could really increase their risk of bleeding. A lot of patients are also concerned because their handout that they get about warfarin says to limit alcohol. And this is because it can increase the risk of bleeding. But sometimes if we're telling patients that and we're not really thinking that they would be able to do that or for quality of life purposes, we usually can say that less than or equal to about 1 drink a day is safe to do, but also mentioning that sometimes people think, they can average this, so if they don't have any alcohol the whole week and then they have 7 drinks on one day, just kind of pointing out that if you could explain to them the reasoning behind why alcohol is an issue, that's not really a safe thing to do because that could really increase the risk of bleeding on that one day or the next day. And so if they're more consistent having 1 drink here or there throughout the week, then that should be safe to do. It's important to stress to keep the medication out of areas where children or pets could get into it because they aren't aware of all these safety risks. And if someone else, especially a child who's a lot smaller or a pet, has this medication, then it could be really life-threatening to them. And then also to tell their doctor right away if they are pregnant or are planning to become pregnant because warfarin can cause birth defects. So we have patient FM again. And he calls you about a month later and says that there's a new salad restaurant that opened next to his apartment about a week ago, and so he's been having a lot of salads, about 1 kale salad every day for lunch. And he wonders if this will affect his warfarin. And so could you tell him that yes, it could cause his INR to increase, which could lead to bleeding. His INR could decrease or lead to clotting. No, it shouldn't affect his INR because he's been having them every day for the week, or it should not affect his INR because kale is low in vitamin K. Did you say B? Yes, so B is the correct answer. So because his dose that we determined was before this salad restaurant opened, it was based on the amount of vitamin K that he was having before this. And so then he could require a higher dose now to have his INR up within his goal range. But if he was going to continue to do this, and this could be a conversation we have with him, it may be hard for him to estimate if he's going to keep having the salads every day. If he was, then we could think about adjusting his dose based on this. But if he thought, no, I'm going to stop now, then we may just want to, even though his INR could be low at that time, we could keep his dose where it is because he's going to stop eating the salads. And then it would likely go back to where the dose he was being treated before is sufficient. So for INR monitoring, so this is the part where the patients would be seeing you most often in clinic or over the phone. And so we can measure their INR either in the clinic with the point of care testing or in the laboratory. So usually either one is fine, but as we can see in the protocol that I have a little later in here, if their INR is really high and we weren't really expecting it, we can usually retest, and we would recommend going to the laboratory just because it could be more accurate than the point of care testing. But in general, usually the point of care testing is as accurate as we need for what we're dealing with that day. And so then also, it is recommended that we try and check their INR before they take their dose that day, but sometimes this isn't possible based on the time that they're coming in. But just something that if they take it every day at 10 a.m., maybe they could come in at 9 a.m. that morning. But this isn't something that has to be done. And then the change in INR lags about 3 to 4 days. So usually we wouldn't be seeing them that often, but if for some reason maybe they had just gotten out of the hospital and had a change in their dose, and so then you had a more recent INR, we wouldn't want to make changes until we give any dose change about 3 to 4 days to actually have an effect on the INR. And this has to do with kind of back to the beginning of the presentation when we were talking about the mechanism of how it actually works, and then the clotting factors going forward rather than the clotting factors that are already present. And then the metabolism can be impacted by different drug interactions, advanced age, or hepatic dysfunction. So these are things that we can think about when we're talking to patients and think if any of these things have changed specifically, like the drug interactions, or if they are starting any new medications that could be hepatotoxic, just to keep in mind for the future that it may affect the warfarin dose. And so when we're determining what to do what to change about the patient's warfarin, we can consider different transient factors. So these are temporary things that may affect the INR, but are not permanent changes. So if that patient FM had the salad restaurant one time and then wasn't having it again, then that would be more of a temporary factor than a permanent change. Alcohol intake, if they had any recent illnesses, specifically like vomiting or diarrhea, but even just fevers or colds can affect the INR. Recent hospitalizations or procedures, and this is because usually doses are held, and then the 3 to 4 days down the road when we're checking it, their INR could continue to be affected. If they had any missed doses or adherence problems, and so this is something that we can ask about, like cost of medications. Usually warfarin is pretty affordable for patients, but if they're having trouble with adherence, a lot of times with any medication, it could be a patient is not able to afford it or isn't able to get it from the pharmacy, so that could be a time to assess that and if their medication is affordable. And then if there's temporary interacting medications, so if they had 2 or 3 days of an antibiotic and now it's done. These are all things to think about if they're just temporary reasons, but not maybe something to make a full dose change for. And so on our protocol, there are 2 different columns, and one is for if there are transient factors present, and then another column of the action to take is if the answers to all of these questions were that they're not present. And so at UVA, the clinics who do have the nurse-driven anticoagulation protocol, it can be managed by nurses once a patient has completed their bridging and then they've had the 2 consecutive INRs. So they should be on a stable warfarin dose within their goal range before they're switched over to this protocol. And so we usually follow up on the INR every 1 to 4 weeks, depending on any dose changes that were made in their most recent INR. And that can, on the specific protocol, depending on any changes you're making, it will guide you to when you want to recheck their INR. So specifically to point out, like we were talking about earlier, if they had an INR of greater than 4, that's usually a time where instead of making a dose adjustment right away on that point of care test, we would send them to the lab to have that rechecked. And then if it is the same, then we could make changes accordingly, but just to make sure that we're not making changes on a false result. And then there are 2 different grids on the protocol, and they're based on the patient's INR goal. So the 2 to 3 or 2.5 to 3.5 that we were talking about. And I have the protocol coming up in a couple slides. And so usually, depending on the INR, we would change the dose based on a percentage of their total weekly dose. So we would add up the milligrams they're taking throughout the whole week. And this can be important because a lot of patients aren't taking just 5 milligrams every day. Some patients may be taking 5 milligrams and 2.5 alternating. And so we look at their total weekly dose, and then we can multiply it by the percentage that we want to change it by, and then either add or subtract that depending on if we're increasing or decreasing their dose. And then we can divide that back out by 7 days. And so this may not come out to be their exact tablet size, but we can either give a different strength on differing days, or we can, if we can get it within that window, because usually the percentages are like 10 to 15%. But so if you can get it within the window of percentages with the tablet strengths that they have, then that's what we usually try to do. And the newer protocol tries to use the 5 milligram tablets. But we never want to have a patient use smaller than a half a tablet. They're all scored. You can see them all here at the bottom. And so it's okay to use halves, but when you're getting down to quarter tablets, then it's really hard to tell what they're actually taking, and their dose could be pretty different from day to day. And so each of the different brands, whether it's the name brand, which is Coumadin here at the top, or different generic brands, the different strengths are all the same colors. So that's another thing we could ask patients about. Sometimes they have old medications on hand and they say, oh, can I just take this one? So if someone says they have 2 milligram tablets on hand, and then you ask the color and they say it's yellow, then that would be something you would think, oh, then this might not actually be the 2 milligram and it's the 7.5 milligram, and so then you would warn them to not use that medication. So I think that's really helpful, which isn't something we have with a lot of other medications, that the colors are consistent through all the different companies. And so this is the protocol that I was referring to. And so based on their INR result on the left, you can decide do they have transient factors or not, and then proceed with each column. And so this is the goal 2 to 3 chart, and then this is the goal of 2.5 to 3.5 chart. So then I have some questions that we're going to go through, and in case you don't have this, I forgot to print this out, I can pull it back up on the screen for you to look at. So FM comes back to the clinic for his monthly INR check, and his goal is 2 to 3 because he has non-valvular atrial fibrillation. He's currently taking 7.5 milligrams every day, and he's continuing to have his 1 kale salad each day for lunch. So his INRs, you can see over the past 3 months were 2.2, 2.7, 2.5, but then today is below his goal at 1.8. So what actions would you take? And so if we ask about, so we asked him about that, and then his response was that none of them existed. And so then based on that chart, sorry, it was already there, we would see, so he would fall here in this section. So no transient factors exist. And so then we would say that we could increase his dose by 10 to 15%. But we don't need to think about bridging for him, and that is because he doesn't have a mechanical valve or a new clot. And so even though earlier I was saying that a lot of times we do this for all patients, but because he just has this 1 INR slightly below range, and because he's being treated for AFib, we probably wouldn't need to go back to bridging for him. And so we could increase his weekly dose by 10 to 15%.
If he said that I might not eat a salad every day,
Mm-hmm.
then it would be based on the transient, that it would be a transient event since he did it for a week.
So
So
if it was a day he didn't eat it, then you might think his INR would be higher instead of lower, and so then that answer might not be. You might be thinking, oh, this must be from something else. Then, if he maybe told you sometimes I eat 2 salads every day, and then it was 1.8, then that could be more consistent with the lower number. But usually, if he didn't have the salad that day, then you would think his INR would be higher. Does that make sense?
I'm just trying to figure out the transient versus non-transient.
Yeah. So it may help to think about it as if the transient factor that's there, if it matches the direction that the INR is going, and if it seems like, oh, you would expect this factor to make it go down, and then it is going down, then you could probably think along that pathway and use that section, and then when you recheck, if it's improved, then you would think, oh, then that's probably the cause, but if not, then you could make changes. But if the factor is you would expect it to go in the other direction than the INR, then you may not, then you would probably use the column without transient factors. That's a good point. Okay, so if we were to change it by 10 to 15%, do you have any ideas of what we could change his dose to? So he was taking 7.5 milligrams every day. Okay. So we can go ahead and just look. I have all the numbers here, so you can follow along. So, oh, well, I think I forgot to change the slide. I was supposed to put here 7 milligrams. I'm sorry about that. But, so I did the math with 7 milligrams. Sorry. But, okay, assuming he takes 7 milligrams a day, we would multiply that by 7 days a week, so 49 milligrams total over the week. And so if we were increasing by 10%, that would be about 5 milligram increase, and 15% would be about 7.5 milligrams increase. And so anywhere within that range should be safe for him. And so we want the new weekly dose to be between 54 and 56.5. So then if we were to divide it, that comes out to be 7.7 or 8 milligrams a day. And so because he has 2 milligram tablets, the easiest for him to do would be the 8 milligrams a day. If he had 5 milligram tablets, then we could do 7.5 with the 1.5 tablets. But he has 2, and so going to 8, which is, even though it's at the top of the range, that's fine as long as it fits within. So for him, we would go up to 8 milligrams from 7 milligrams a day. And then when would you like to check his INR? I can go back to the protocol. So he's in this section. Yep. Yes, so for him, we would check him again in 2 weeks and see if he's had any improvements. Okay, now we have another patient. So FM is all taken care of now, but CW comes in, and she is a 68-year-old female with a mitral valve replacement, and so her goal is 2.5 to 3.5, and she is taking Warfarin 5 milligrams every day. So she's been within range the past couple of months, but today her result is 3.7. So what are some other questions you may ask her?
Any transient factors, diet changes, and doses, and medications?
Yeah, perfect. So diet changes, if they've taken extra doses by accident, going through the list of over-the-counter, prescription, vitamins or herbals. Recent illnesses is something that is often forgotten when we're thinking about transient factors, or any increase in alcohol intake. So she stated that she did run out of her multivitamin gummies for about 1 week, but she purchased more this morning, and so she's resuming taking them. So how would you most likely proceed? You can continue the dose because she's resuming her vitamins. Decrease to 2.5 on Wednesdays and 5 on all other days, which would be the dosing for a 5 to 10% reduction. decrease the dose today by a half a tablet and then resume with 5 milligrams daily, or she could hold today's dose and resume with 2.5. Yes, that is correct. Did you say C? I thought you said C. Yeah. So if we look back at the protocol and the 2.5 to 3.5 goal, so she does have a transient factor, and it's temporary because she is going to resume her vitamins again. And so if we looked in that section, it would tell us to do a half a tablet today, but then resume her normal dose. If she had said that she ran out of vitamins and didn't want to continue taking them at all, then that may be different, because rather than a temporary factor, that's going to be now of a long-term change. So we can also ask, a lot of times with vitamins, the specific vitamin they're taking, the different, even the regular everyday multivitamins, some of them have vitamin K and some of them don't. And then even, I thought it was interesting, like the one-a-day women's, the tablets have vitamin K, the gummies don't. And so even just asking them the specific one they have, or if they have the bottle, they could look on the label for you. Just because we don't want to make changes, assuming that there was a change in their vitamin K intake when their vitamin doesn't even have vitamin K in it. And so when will we recheck her INR? Yeah, so hers we would check in 4 weeks, and that's also back on the protocol, the same place where you would find where to make that change. And then to wrap up, we'll just talk a little bit about the DOACs. So I didn't go too much into them, but just to kind of understand their place in therapy for patients who are on warfarin, and you may have patients switching over. So there's the factor 10A inhibitors. So this is Eliquis, Xarelto, and there's two newer ones, Saveza and Bivixa. And then there's also Pradaxa, which was the first one that came out. And this one's mechanism is a little bit different. It's a direct thrombin inhibitor. So the 10A inhibitors prevent the body from making thrombin, whereas the Pradaxa blocks thrombin itself. So these agents differ from one another when we're trying to determine which one is being started. Each of them has slight differences in its metabolism, the way it's eliminated, their dosing, whether it's once or twice a day, whether they need to take it with or without food. There's different indications that are indicated for some, and then others don't have those indications. Different INR thresholds for when we can switch from warfarin, and then differences on patients' insurance formularies. So these are the different thresholds for if a patient is maintained on warfarin, but we want to switch them over. We can't stop warfarin and then start one of these agents on the same day, because just like it takes a little bit of time for the warfarin to start working, it also takes usually 4 to 5 days for it to stop working and have their INR go down back to normal. So we don't need it to go back to normal, but we do want it to be lower than therapeutic anticoagulation. So for each one, there's different thresholds. So there's either between 2 and 2.5 or 3, depending on which DOAC we're starting. So picking up where we left off, talking about some of the pros and cons of DOACs versus warfarin. So there's less drug-drug interactions because of the different metabolism pathways. There's not the drug-food interactions, such as the vitamin K intake differences don't affect the absorption or the efficacy of the DOACs. There's not the routine monitoring required of the INR as we need with warfarin. The only monitoring that we would need is a couple times a year we would have to check their renal function just to make sure that they're staying within a safe range to be continuing taking the DOACs. In the clinical trials, there was less major bleeding. The only one that if there was more bleeding was GI bleeding. But there was less intracranial bleeding, and so the outcomes for patients were better in the trials when they compared DOACs versus warfarin. The onset of action is also quicker with these agents, and so we don't require bridging with parenteral agents, which is a lot easier for patients outside of the hospital, and there's less influence of hepatic dysfunction on their metabolism. Some cons of the DOACs are cost. So warfarin is usually a lot more affordable for patients, but depending on their insurance and then each year that these remain on the market, they do get more affordable for patients, and many of the insurance companies are actually paying for them now. There's no way to monitor these, so that's a pro in some ways because patients don't have to continuously go get lab work done. But if we ever were worried that they were at a higher risk of bleeding and wanted to see how anticoagulated they are, the assays that we do to measure this are not as straightforward as with warfarin. There aren't reversal agents that are readily available, so with dabigatran there is Praxbind, which some hospitals do have, but a lot of times patients are on the other DOACs, which don't have a reversal agent readily available until recently. That just came to market. So currently most institutions don't have this medication right now, but in the future, hopefully this will be something that is available. They're also renally eliminated, so this is something that wouldn't be affected with warfarin, but we do have to pay attention to this with the DOACs. And there's limited data for patients that have end-stage renal disease and patients on dialysis. But recent studies did come out, but that there was less bleeding when patients on dialysis took a DOAC versus warfarin. And this is pretty recent, which would be a really big advance for these patients if we could continue to get more data for this and then start using these for this patient population. And then lastly, these agents can't be used with mechanical heart valves because the original study with dabigatran found worse outcomes, and then so the remaining DOACs weren't tested in this population. And so here's our last question. So this is a patient who has pretty consistently fluctuating INRs at each visit and answers no to all of your questions for any reasons why it could be fluctuating. And so you think maybe he's a good candidate for a DOAC and set up an appointment for him to see his provider. But he asks you first if he would have to keep getting his blood drawn. So what do you tell him? And there may be more than one correct answer. So that he does, yes, he has to continue getting his blood drawn, but it's instead of the INR, it's a different laboratory test called the factor 10A level. Or is it yes, that they are monitored with the INR, but we just have a different goal range? Or is it no, that they don't require INR checks, but he will have to have a couple more tests so that he can determine when it's appropriate to switch agents? Or is it no, because they do not require INR checks, but we do have to monitor renal function periodically? And so the answer to this one is C and D. So just for that beginning part of the time as we talked about, because you have to start each different DOAC at a different INR range. We want to keep checking the INR until they get below that point that it's safe to start, and then just periodically throughout the year making sure their renal function remains stable. And then lastly, just some information on special populations. So patients with ESRD on hemodialysis, as I referred to a little bit earlier, that there's new data out there that patients who, when they compared taking warfarin compared to apixaban, there was less bleeding with apixaban, and so we may think this could be applied to all of the DOACs, but right now we only have data about apixaban. And so if we were going to go ahead and do this for these patients, we would probably go with apixaban for now, just because we know the most about how that works in this population. Also, cancer patients. So oftentimes patients with cancer are at a higher risk of clotting, and so many of them require anticoagulation. And recent studies with DOACs were found to be non-inferior to low molecular weight heparin. But right now, the only actual labeled indication that we can use for these patients is low molecular weight heparin. But when we compared that with warfarin, there was actually an increased risk of bleeding. So in the past, we really could only use warfarin or Lovenox in these patients, but these recent studies were actually non-inferior, and so this could also be an advancement for this patient population, similar to the HD patients. And then lastly, for pregnant patients, we can still only use Lovenox or heparin because the safety of these agents hasn't been tested with its effect on the fetus and the patient. And then our last part is about reversal agents. So we know that for heparin that we do have a reversal agent of protamine, which has been around for quite a while. As well as warfarin, we can use vitamin K or Kcentra, which is 4-factor prothrombin complex concentrate, or 4-factor PCC. But then we have the DOACs with apixaban, rivaroxaban, edoxaban, and batrixaban. Just earlier this year, there was a new agent, Andexa, that was approved by the FDA that has shown some potentially good data, and some of it is also a little bit controversial, so we'll see how this finds its place in therapy. But right now, many institutions don't have it readily available as it's pretty expensive, and the manufacturer hasn't actually created enough yet to have widely available. But in the next coming months or years, we can see how this fits into our therapy. And there's also some data that Kcentra can be used in these patients as well, because up until now, this was really our only option for reversing these agents. And then lastly, dabigatran, which was the first DOAC, does have a reversal agent of Praxbind, and it's also the only one that's dialyzable. So if you have time for the patient to go on dialysis, it can be removed, but oftentimes we need to reverse a bleed much quicker than dialysis would be able to do that. So overall, this presentation, I hope, showed you that both a high and a low INR can be dangerous because then we have increased risk of clotting as well as bleeding. And there's many factors that can cause the INR to go up or down, and some of them are temporary and some of them are a chronic increase or decrease, which we could change the dose for. Patient education is really important, no matter which of the anticoagulants we're starting, whether they're the more straightforward or more complex, such as Warfarin. It's really important that patients are knowledgeable about these medications and they know both the importance of taking them as well as the risks. And you should always feel free to reach out to the pharmacist in the family medicine clinic or any pharmacist that you have around, as well as the prescriber if you have any questions or if you feel you just want to run your plan by somebody before making any changes. And I'll now take any questions.